quality improvement process. It needs these elements in it, and I'll just go through, if I may, the processes in medical audit to discuss those a bit further. Audit always has a cycle, or as we'll come to in a moment, a spiral. It starts by choosing a topic. What are you going to investigate? Shall we say the number of your patients who have thrombolysis treatment after myocardial infarction within a certain period when they get to your hospital. You need to agree the standards, and you need to agree those standards before you start, because inevitably you'll find if the results aren't what you expected, people will start to chip away at standards and say, oh, that's not really what we were going to do. So you need to make sure that standards are there beforehand. So we'll say thrombolytic treatment within 30 minutes of reaching the hospital. You then observe what is actually happening. Set up a data collection exercise to see, for a certain number of myocardial infarction patients, how many, when they got their thrombolysis, did they get their thrombolysis at all? What period of time did they get it at? If they didn't get it, was there a good reason for not having it? You then sit down and see how well you've done, and it's likely, if you've chosen the topic correctly, that you'll find you are not doing as well as you thought. You then agree what needs to be changed so that your performance can improve, so you now do meet your standard, and you implement those changes. And I say it's a cycle because you should then do the whole thing over again to show that you've achieved something by your changes. I say, oh sorry, can you go back one? I say a spiral because you have the option, if you find that you have got all your patients thrombolysed within 30 minutes, you may decide, well, let's try and be a little bit better. We'll try and do it within 20 minutes. So you could change your standard to thrombolysis within 20 minutes, do the audit cycle again. Audits come in all shapes and sizes. They may be large or small. I get involved in a large national audit. You could do one around your own particular care, just around one aspect of treatment with one doctor. You can just use it in one specialty, doctors. You could try it in the whole group, involving, as Jim Clark was talking about, his team for vascular surgery, involving vascular surgeons, radiologists, intensive care, nurses, and so forth. You may be able to do it in a week, I doubt it. You may be able to do it in a month, or you may go on for years. All good audits will take longer than you think, just to warn you. First thing to do, and critically important, is to choose the topic correctly. Some suggestions as to how you might look at topics that you choose. You want to look at things that are important. So you might look at things that have you to a high volume in your practice, ones that are high risk, or indeed possibly ones that are high cost, because we have an obligation, certainly in the UK, we're supposed to spend the money wisely, not to waste money on ineffective, high cost interventions. You may already have evidence that there is a serious quality problem around a particular topic, so that you'll use audit to investigate that further. It is helpful if you've got good evidence to agree standards. As far as thrombolytic treatment is concerned, there is good evidence that giving people thrombolysis after myocardial infarction in a short period of time improves the outcome and saves lives. Other aspects, you may find that you take 6 different clinicians and they have 6 different ways of treating the condition, in which case there's little point in trying to do an audit because you never agree on what standards you should set. And finally, is there any chance of change once you've done the audit? If you know that to solve the problem is going to need a new hospital or 6 new doctors in your department, and there's no chance of getting those, there's little point in starting down this road in the first place. You have to agree the standards, and you may well be aware of this idea that you can divide medical interventions practice into the structure, the process, and the outcomes. What people are chiefly interested in is the outcome. For example, in Norwich, we've been recently looking at the outcome of cancer treatment in our hospital, and what patients would like to know is what are the chances of my surviving for a certain period of time, say 5 years, as good in this hospital as in another hospital, or in the UK as a whole. If you find out that their results in your hospital are as good as elsewhere, that's great. If you find there's a problem, it doesn't tell you where the problem is. Maybe a problem with the surgery, with the medicine, with the radiation therapy, or whatever. in which case you have to go back a stage and look at the structure and the process. Do you have the right departments? Do you have the right treatment protocols and so forth? Depending on the topic you're looking at, you may choose standards around any of these three areas. The standards should be explicit and measurable. I mentioned earlier about you can do case presentations and morbidity and mortality meetings. Generally speaking there, the standards are implicit. You present a case to a group of clinicians and they sit around, they say, I think that was good care, or I think that was bad care. And when you actually ask them to say why they choose one or the other, it's all a bit hazy. Maybe very good, they're experienced doctors, but you can't actually sit down, get them to write it on a piece of paper, something that you can measure. So ideally you would like something really hard. 30 minutes is a good time to have a standard around. Everybody can measure 30 minutes on a clock. Observe current practice, that's reasonably straightforward as long as you tell everybody that you're going to do it and you've got robust arrangements to collect the data. There's always a temptation to collect data about everything. You should collect, in fact, as little data as possible, because otherwise you will get poor data returned and you won't get all the data you need. Assess agreement with standards, that's fairly straightforward. Agree and implement change, this is the really difficult one. From my own experience of sitting in lots of audit meetings where people are presenting audits, somebody gets up, they've done quite a lot of work, they've collected the data, they do the presentation, and people say, that was interesting, and then they go on to something else, which is a waste of time. The difficult bit is to get change taking place. So if you find there's a disagreement between what you thought you were doing and what you actually are doing, you need to agree what you need to do to change it. It takes time and resources to change that, so you need to make sure they are in place. And you need to go and tell everybody and implement the change. There is a lot of data in the UK now, and I suspect in other places as well, about the difficulty of achieving change. Doctors are human beings, and as we all know, going up to somebody and explaining to them what you think is the right way of doing something doesn't mean they will automatically say, thank you very much. I'm an idiot because I haven't done it that way before. Thank you for showing me what a stupid person I am. I will go and change my practice. People do not react in that way in any part of their lives, and they don't react that way in medicine. Trying to get people to change their practice from a practice they thought was good and worked well is hard work, and you have sometimes to be quite devious and cunning to get them to change. Assuming you are that sort of devious, cunning person who succeeds in getting your colleagues to change how they work, you then have to sustain the change and make sure that you don't fall back into the bad old days of how you were working. And then, as I say, you re-audit. You go around the cycle and do it all over again. And if it's a successful audit project, you'll find that yes, whereas previously only 50% of your patients had their thrombolytic treatment within 30 minutes, you've now got up to 75%. That's good news for you, you're being a better doctor, it's good news for your patients. However, you really wanted 100%, so you have to go around again and see what you can do to further change the way you work. I have to say that audit in the UK has a mixed history. As I say it at the moment, it sounds a wonderful technique, everybody should be doing it, it must work well. It in fact has been badly done in the UK. I said that the government gave hospitals, family doctors and others quite a lot of money to introduce medical audit. When they went to see where the money had gone after 3 or 4 years and what change it had had, the answer was very little. There are a number of reasons why that has been, and I'll share those with you so that if you are going to be looking at using audit as a quality improvement tool, you could learn from our dismal experience and try and improve it in your own hospitals and family practices. The first thing was that audit was introduced as an end in itself, so that you get people saying, I must go and do a medical audit, I've been told to go and do one, I have an audit meeting on Friday, I need something to talk about. It's actually the other way around. You should feel that there is a problem with your clinical practice, or you should feel that it's an area where you need to demonstrate that you are good at what you do, and that medical audit is the appropriate tool to use to do that job. Unfortunately, being told to go off and do an audit project without any indication of why that topic or anything is important has led to a low status for audit and poor motivation. So that it has got fobbed off to junior members of staff who do it poorly. If you turn it the other way around and make sure it's an improvement tool that you use to help you give a better quality to your patients, you have a better chance of making it work. Going along with that, as I say, is a poor choice of topics. So people pick topics that are really trivial, they are not serious problems with patients' health, and so inevitably that downgrades the status of medical audit. Whilst the government gave money to hospitals and family practitioners to do audit, they did not give extra time for doctors to do it. And it does take time. It takes time to plan audits, to do them well, to implement the change. You almost need to have the philosophy that if you want me to start doing medical audit, what do you want me to take out of my job that I'm doing at the moment? Following on from that, you need assistance and support, and you need an audit resource to help you do it, because doctors, unless they're going to spend too much time doing audit, are not going to have the ability to do it all themselves. Poor planning of audit projects will also inevitably lead to bad results. That's the same as any other aspect of human activity. And as I say, you do need proper resources, and that is not just money, but people, time, and so forth. What else goes wrong? Well, 2 or 3 people in a department have a good idea about an audit, but they don't tell everybody else who's going to be involved. And inevitably, the psychology is that they won't participate, and therefore the audit will not be as comprehensive and systematic as it should be. There's also a tendency to do audit on other people. I'm an anaesthetist, so I will go and audit what the surgeons do. Not surprisingly, when I go and tell the surgeons what I found, they are resistant to what I tell them, and I'm no different from anybody else, so it works just the other way around. If you are going to audit an area of activity, you must make sure that the people whose activity is being audited are part of the plan. And then, as I said before, there is a difficulty about getting people to sign up to change, if change is needed. And people feel almost that they lose energy. Once they've done the audit, got the results, they lose the energy to do the change and to go up and make sure they've achieved some change and it has been sustained. It is a complete cycle. You can, however, get successful audits to work. And there are many of them. I'll talk about one which I'm part of. I wouldn't say it's my success because I didn't set up this audit. I've joined it later once it was running. This is a national confidential inquiry into perioperative deaths. That's anybody who dies within 30 days of an operation. It was started because there were perceived to be failures in care, in anaesthetics and surgery around some of those cases. There's almost a feeling in some people that if somebody dies after an operation, there must be somebody to blame. That's obviously not true, but there are a number of cases where it is possible they would not have died if the care had been better. So it addresses an important topic. I have to say the standards are not explicit, so it fails as an audit on that point, because it is based on doctors sitting in a room deciding on their experience whether care is good or is not good. But by having quite a number of doctors in the room, then you get a reasonable consensus of care. You also make sure the doctors all come from hospitals that are doing proper work. They are not all professors or academics, so they are in touch with the real world of surgery and anaesthesia. It's a success because it covers all the UK, excepting Scotland. They have a separate inquiry in Scotland because they are different there. But it covers all the United Kingdom. When it was started, people went around the country talking to hospitals all over the country to involve them, and now more than 88% of the doctors participate, of the surgeons and the anaesthetists participate in the inquiry. When they tried a similar exercise in Germany, they had 15% response. So we feel we've done very well for the UK. As a result of its examining care, the inquiry publishes recommendations, and it's an annual inquiry which has been running now since 1989, so we have gone round and round the loop. As I say, it is a success. It's been running for nearly 15 years. Some of the things that it has achieved, there was a large amount of operating going on emergency patients after midnight done by inexperienced doctors. That has fallen considerably since the inquiry started and started making recommendations that this should cease. Too much of the emergency surgery was done by inexperienced junior doctors. There is now much better involvement of senior doctors. And it identified a problem that if you came in at 8 o'clock in the morning with an emergency condition, you waited till 6 o'clock in the evening because the theatres were full of elective planned operating. We have now achieved in most hospitals the provision of daytime theatres available for emergency operating. So you have much better chance of having your operation fairly soon after 8 in the morning rather than 10 hours later. So the inquiry does work, and the audit method does work in that area of an important topic with serious problems of care. Medical audit, leaving that aside for the moment, is not the only quality initiative going on in the UK. Sometimes feel we are drowning under them. The government has introduced an organisation called the National Institute for Clinical Excellence. And one of its briefs is to introduce effective treatment on a uniform basis throughout the country. And it is doing this by taking new innovations, should they be new drugs, new orthopaedic operations, new vascular procedures and so forth, considering the evidence and deciding whether the National Health Service should introduce them or not. The intention is that they will only introduce treatments that have good evidence, not just enthusiasm on the part of the person introducing them, but there is good evidence. If it gets the thumbs down, then that treatment should not be used anywhere in the country. If, on the other hand, they feel it is an effective treatment, then everywhere in the country should introduce it immediately. We had situations in the past where a new treatment would become available, but only one area of the country would be able to afford it, another area would spend the money on something else. So you had patients who, whether they had the treatment or not, would depend which part of the country they lived in. Jim Clark may or may not be upset that this institution recently looked at stents for aortic aneurysm repair and decided the evidence was not yet good enough to recommend wholesale implementation. So we are unlikely to be doing those at the Norfolk and Norwich Hospital for the near future. They also tried to stop doctors doing ineffective treatments. This is mainly through the implementation of guidelines, again, drawing on evidence, drawing up standards of best practice, and then expecting doctors to adhere to those. And as we'll hear later on from David Rouse about day surgery, if it's not necessary to keep a patient in hospital for 10 days after a hernia operation, then we should stop doing so. I have to say that the guidelines is again a change in the way that we practice medicine. It is taking away, my colleagues would say, the ability of an individual doctor to consider a patient and do what is best for that individual patient, and it is taking and saying this patient has a particular condition and treating the condition rather than that patient. And the introduction of guidelines is a difficult and controversial area for medicine in the UK. There are also measures being taken to prevent medical errors. There was a paper published in the United Kingdom about 2 years ago, which showed that 1 in 10% of patients admitted to hospitals in the UK suffered a complication of their treatment, and about half of those complications were preventable. So we had a patient who had an allergy to penicillin when it was administered. About half of those, it was the first time it was known about, so that's bad luck. But about half of them It was written on their notes that they were allergic to penicillin, but someone still prescribed it and gave it to the patient. So 1 in 20 of the patients in our hospitals is being harmed by errors on the part of doctors, nurses or other therapists. That reflects evidence and that's been shown for medical error rates in America, in Australia, in New Zealand, and therefore I suspect may well also be true in Cyprus. We are taking great measures to try and prevent medical errors occurring, but it is very difficult to do. And there are also measures around, are you a good doctor, to publish outcome data for hospitals and for individual doctors. You can already look up on the website and check how many patients died within 30 days of emergency surgery at the Norfolk and Norwich University Hospital. And you can check that against the national average. If you are a patient in Norfolk, I'm not quite sure what you do about that, because there are no other hospitals within near to Norwich for them to go to. But the information is being produced, the intention being that it will force hospitals to try and improve their practice wherever they can. Shortly, next year, the Department of Health, the government in the UK, is going to publish outcome data for adult cardiac surgery, the figures assigned to the cardiac surgeon. It's interesting because the cardiac surgeons have for many years said that they are the most important person in the room and it's all down to them, but now that the figures may come their way, they're starting to say, well, of course they work in a team with anaesthetists, nurses, cardiologists and so forth. But nonetheless, it's going to be down to them. Whether or not that will improve outcomes, improve the care given to patients, is the subject of enormous argument within England and the UK. But whatever the benefits, arguments and so forth, the government is determined that it will happen. There is also clinical governance, which is the second part of the title of this talk, which is another set of management jargon that was introduced about 3 or 4 years ago now. This is looking at the way that patients are cared for in hospital. I've put up 7 pillars there to remind me, because there are 7 elements to clinical governance, and there is a famous book in the English language called 7 Pillars of Wisdom by T.H. Lawrence, who fought in the First World War in Arabia, so therefore it's nice to give it a shorthand. The 7 pillars are clinical audit, which we just talked about. Then there is risk management, which is all about trying to prevent errors, medical and otherwise, to patients in hospital. There is clinical effectiveness, which is, by and large, the work that NICE, the National Institute of Clinical Excellence, is doing around using interventions that are proven to be effective. There are 2 around staff management, making sure that your staff, you have the right number of staff in place, at the right time, the right skill mix, and that you look after your staff, develop them, send them on training programs and so forth. Given the way that some of the staff are actually treated, that sometimes is a bit difficult to understand. There is one around the use of information, because I said very early on, how do you prove you're a good doctor? You need information to be able to do that. And information around clinical activity in the UK, around how doctors look after patients, is very hard to come by. We have lots of information about our numbers, how many patients were treated, how long before your outpatient clinic, but very little information around the clinical outcomes of patients. The sort of information that Jim Clark was giving, that 50% of amputations will be dead within a year, is very difficult to get out of the information systems in the hospitals that we have at the moment. And the final one, which is really causing us some trouble, is patient involvement. This is the concept that the patients should be much more involved in not just their own individual care, but in the way that the services are organised within a hospital or a family practice, and the way that services are organised within an area. Now, it's true that if you tell patients and involve them in their particular care, explain to them why they need to stop smoking because of their claudication or other aspects like that, patients generally will cooperate more with their treatment, will get more benefit from their treatment. But the idea that you should ask patients about whether this particular hospital should be choosing to do screening for cervical cancer or screening for aortic aneurysm incidents comes very difficult. It's very difficult for doctors to take on board, to comprehend, to go on with. It is interesting that there's yet another regulatory body in the NHS that comes around and inspects hospitals, how they manage clinical governance. The hospitals always do badly on patient involvement. We think we talk to patients, we think we involve them in the bits that they need to be involved in, but generally it appears that we are not doing very well on that. And I have to say it seems unnatural. Many of the aspects that we are asked to look at seem unnatural to doctors at the moment. And another change in the way that doctors are interacting with society. So I would like to start to draw things to a close here. I may have been, shall I say, pessimistic about the use of medical audit. But medical audit can be successful, can be a very powerful tool to determine how good quality is. I've put there, audit is good to show how research works in the real world. There is always, as you know, a gap between doing an intervention with a research team on a particular group of patients. It's then difficult often to apply that to patients who you meet every day in the clinic or in your practice. Audit is a good way of finding out what actually happens and what the difficulties are in applying good practice to real patients. It's important to let you know when you are not actually doing what you think you are doing. For example, in myself, in anaesthesia, we think that we use invasive monitoring, direct monitoring of venous pressure on all our sick patients who come to theatre. You do the audit, you find that you don't. And finally, it can help you answer that question when somebody comes through the door, are you a good doctor? You can say, yes, I have the information, here it is. My figures of my practice are as good or even better than the next man down the corridor. Thank you.
Thank you very much, Dr. Gray. Are there any questions? Thank you very much.
Thank you very much for an excellent lecture. There is no medical audit in this country. How do you think we should start doing it?
I wouldn't want to examine the quality of the care that you give, because if you are not examining it at the moment, I can tell you that it's not as good as you think it is. And that's no criticism of you, because you are no different to all the other doctors around the world. That we all come to work wanting to do a good job, trying to do the best we can, work conscientiously and so forth. But when you actually look to see what you do, there are problems. So I think you should start by looking to see how you are going to look overall at the care that you give, what information you need to examine that care, and then use a variety of tools to look, and medical audit will be one of those.